So guys, let's continue where we left off. So we said that with I'm just okay. So guys, please watch part 1 of this before you come and watch part 2, so that we can be on the same. We can be on the same page with the rest of us. So we said that the causes. We did explain that it can be an increased load, as in oral intake or IV, like drugs that have got potassium given to a patient as an IV. And then we can have shifting of potassium from the intracellular to the extracellular, and then renal let's say excretion impairment. So that's what we have. And we did explain that as long as you've got a good renal function, you shouldn't have hyperkalemia from just oral intake, because of what we explained earlier, that it's called a potassium adaptation. So when the body realizes that it's receiving a lot of potassium, it will take what it needs and excrete what it does not need, such that if the increased intake continues, the oral intake continues for days, the same amount that goes in will be the same amount that is taken out, just like that. So it's called potassium adaptation. So that's why it's very difficult for someone to get hyperkalemia from just oral intake, not unless they've got some kind of renal impairment. They've got a potassium excretion problem. IV, we said this one has got a potential of killing you there and there, depending how much you were given, because the body will not have enough time to adjust and activate the mechanisms of excreting potassium. So your ECG changes will take place even before the body can sort of try to deal with the increased potassium intake. We did speak about shifting. We did speak about catabolism, as in like tissue destruction, like trauma, both crash and non-crash. We did speak about hypothermia. We did speak about burns. We did speak about cytotoxic drugs. We did speak about radiation, oncology now. And then we did speak about acidosis. And we said that with acidosis, the acidosis that causes hyperkalemia is mainly metabolic. Respiratory does, but it's not so significant. It doesn't result, or it doesn't cause a lot of changes in our potassium concentration. So that's why it's ignored. And then also your organic acids do not cause it, like your ketones and your lactic acid. They do not cause. And then now we said, so we spoken about, and we did explain that for you to get, please go and watch that part, guys. I don't want to waste time and repeat the same thing, because we said that when you've got acidosis, so this is the blood vessel, we've got acidosis, so when you've got acidosis, by definition, you've got a medium that has got a lot of protons in it. So the protons that are here, they will move down their concentration gradient and enter the cell. This is acidosis now. So they will enter the cell. But when this happens, to maintain chemical neutrality, potassium, a cation must go the other way, and that happens to be a potassium. So that's how you get hyperkalemia with acidosis. And also we explained how do you get with hyperglycemia, how do you get acidosis? And we said that with hyperglycemia, you've got glucose that is osmotically active, so it draws water to this side, and once you do that, you end up creating an increased concentration of potassium here. And then since you've got an increased concentration, so the gradient, you're going to have a higher concentration this side, so the potassium will go the other side, will follow the water because of the high concentration. So it's gonna move down its concentration gradient. Remember, you don't need active transport if you are going down a concentration gradient. So that's your glucose. So it's gonna pull, and then you become a hyperkalemic from a high osmolality. In this case, it's glucose. There are other things that cause high osmolality as well, but in this case, it's glucose. So that's one way of having, so you develop hyperkalemia because of this mechanism. But now the problem is you've got this glucose also causes osmotic diuresis, so you lose potassium in the urine. So basically, you have a patient who's got hyperkalemia, but the total stores of their potassium in the body is reduced because you've got a loss. But you still have hyperkalemia on your sample, but the intracellular potassium is depleted. So those patients, they look like they've got hyperkalemia, whereas in actual fact they've lost a lot of potassium by osmotic diuresis. That's what I wanted to explain. So we've spoken about hyperglycemia, and then it's the same thing with hypertonicity. And then what else do I need to? Okay, and then we spoke about insulin deficiency. We've spoken about exercise. So when you've got, and we said, remember what we said earlier on, that insulin drives potassium into the cells because it stimulates that sodium potassium ATPase pump. I'm not sure if I'm forgetting anything, but I know the big one here is this and this. So the biggest cause of hyperkalemia is shifting. This is number one. Then this becomes number two, especially in renal failure patient. So guys, yes, this is a skeleton. Please add whatever that I've not put. This is not I've not covered everything, obviously, but the clinical part of things. Okay, now let's talk about renal excretion problems. So with excretion, you can either have a decreased aldosterone secretion from whatever cause, Addison disease, whatever cause, or you can have a reduced response to the secreted aldosterone, or you can have decreased glomerular filtration from different causes, be it renal failure, whatever, acute or chronic, or you can have you can have this, or acute renal failure, or you can have renal failure, acute or chronic, and decreased, because there's not. That's why I'm putting this, and especially if your glomerular filtration is gonna get to less than 30, that's when you start seeing hyperkalemia. If your glomerular filtration rate gets to less than 30. The reason why I'm not combining this is that because you can have a reduced GFR without really as a drug or a severe dehydration, and if you correct that, and then the patient becomes well again. So yeah. So now let's say we have our patient who has got hyperkalemia. So how are we gonna approach this patient, since we have this in the back of our minds now? So when it comes to managing hyper, so the thing will be the history. On the history, drug history becomes very important. Comorbidities becomes very important. And then obviously how they are feeling, the nausea, the vomiting, the twitching, the weakness, the paralysis, and palpitations, things like that, just feeling unwell and all of that. So yeah, so that would be the history. And Then physical examination. So the main thing here is the ECG, guys. ECG. Yes, okay, you will do your examination. Let me not say ECG, no? Let me say on a physical examination, you know, hypokalemic patient, when they become weak so much that they cannot even lift their hands, they are really sick, because the weakness is ascending. So they've got weakness of the legs. So you can sort of like, because it's ascending weakness of the legs, paralysis if it's so severe, trunk weakness. They won't even be able to sit at that point. They can't. So when they can't lift up their hands, it's really has progressed. So basically, it's gonna be weakness that can. So it's ascending. This weakness is ascending weakness, paralysis, and this becomes very important. When you've got hyperkalemia, you wanna know, are you having hyperkalemic emergency or not? And to decide that, it depends on these two things. So you can have hyperkalemic emergency, or non-hyperkalemic emergency. I know someone else would argue and say, but hyperkalemia is just an emergency. Not really. I will show you why. So with hyperkalemia, you can have hyperkalemic emergency or non-hyperkalemic emergency. Hyperkalemic emergency is a patient who's symptomatic, number one. A symptomatic patient is an emergency. A patient who's got a potassium of more than 6.5 is an emergency, even if they are asymptomatic. As long as they've got this. A patient who's got a potassium of more than 5.5 and has got a renal failure or has got ongoing catabolism, or they've got absorption, like they've got GI bleeding, where you get absorption of potassium, ongoing GI bleeding. So you want to drop their cutoff lower because they've got ongoing, ongoing hyperkalemia. So a patient who's symptomatic, when we say symptomatic, we're talking about some patients who's got weakness, paralysis, things like that, and ECG changes. These are hypokalemic emergencies. And now, how do you manage hypokalemic emergencies? What you need here is, obviously you're gonna connect them to your monitors on SETS probe, all that, cardiac monitors and all of that, monitoring their blood pressure and all of those things. So, but what you want here, also, because they're a sick patient, so they need 2 IV lines, so that whatever drug you want to give, you've got access, whatever. Because remember, when you want to give calcium gluconate, you cannot mix it in the same line with a bicarbonate. So you need 2 lines. So it's safer to put 2 lines. So the management for this patient, you want rapid shifting. And rapid shifting is IV. Guys. You can give a patient your beta agonist, like your salbutamol, your albuterol, while you are still preparing for the IV. But you cannot use IV alone in these kind of patients. So you use the drugs that you use in IV is calcium gluconate with insulin plus dextrose. These are the 3 things that you must give. And calcium gluconate, there are other calcium. It's calcium that we want. There are 2 preparations. You can have calcium gluconate or calcium chloride. Calcium chloride is said to be very irritating to the skin on the site where you are giving it, and can also cause necrosis. So it's painful. So it's better to go with, and also you need a central line for that one. So it's better to give calcium gluconate because you can use a peripheral vein there. Why are we giving calcium gluconate? Remember, calcium is very much involved in an action potential of a cardiomyocyte. This plateau happens because of calcium. So it's very much involved in the contraction of the cardiomyocyte. So this guy, it stabilizes the membrane of the heart to stop, sort of, in a way, you are stopping this ECG changes when you are giving this. That's what you are doing. We are stabilizing the membrane because this membrane is already irritated by the hyperkalemia, to say the least. So it's already irritated. So we are just trying to antagonize what is happening here. So you use the calcium so that you can stabilize your, and you use 10% of this, 10 mils. There are different preparations. Just look on the guidelines because there are different ones. There is this 10 10 10 10 10 15, whereby you use 10% of 10 mils of 10% calcium gluconate, and you use 10 international units of insulin and 50 mils of dextrose. So you give this guy first over 2 to 3 minutes, and then you should have ECG change. Your ECG should normalize after giving this. This is not for shifting glucose. It's not for shifting potassium. This one, it's for stabilizing the membrane so that you get rid of your ECG changes, which we are going to talk about. Okay, so why give so you give this for stabilizing the cardiac myocyte, and then you give insulin to now correct the problem, which is, and we spoke about earlier, that insulin shifts potassium from the outside to the inside. The reason why you give this, remember, insulin stimulates the pump, the sodium potassium pump. It enhances its function, which is to take potassium from the outside to the inside. But we said that that's an active transport. It needs ATP. So if you don't give dextrose, that patient will become hypoglycemic because it's an active transport. It's a lot of work to pump those potassiums against their concentration gradient. So you need the dextrose. And before this is done, the patient blood sugar should be checked. Guideline says that if the blood sugar is less than 13.9, you shouldn't you should give dextrose before you can try and do this. So you need to make sure, if the blood sugar is already low, that patient is gonna have hypoglycemia. After doing this, you are gonna put a patient on an infusion of a dextrose, not infusion of dextrose, so that, because this hypoglycemia that happens with this can take up to 6 hours. The patient's blood sugar must be checked every hour to see if they are developing hypoglycemia because of the insulin there. So basically that's that. So after doing this, and of course we said that you can also add your beta 2 agonists there, and then this is now part 1. Number 2, you need to remove potassium now from the body. So the options are diuretics. Number 1, obviously, if the patient is fluid overloaded, and use with caution. If not, Lasix or thiazide, and we know that loop diuretics are more potent in terms of causing hypokalemia than the thiazides. So you can use that, or you can use you can hemodialyze this patient, hemodialysis. So it's dialysis, but the hemodialysis. Or another thing, before you get there, you can also try Kayexalate. Kayexalate is a gastrointestinal cation exchanger. So the class of drugs there. So the choice is Kayexalate there. So after doing this, you need to get to this. No, unless there are